Hi, I'm Dr. Scott Worden, the TOS guy, and we're live streaming from beautiful downtown Sunnyvale, California. We're finally getting some sun here. I hope everybody else is starting to see spring show up. I want to let everybody know that we have a very interesting talk coming up in 2 weeks' time on April 1st, April Fool's Day. We're going to have a roundtable of three highly experienced TOS physical therapists, including Steve Talakowski, who's talked with us several times before. But this will include a couple of additional physical therapists who have different approaches and are highly experienced in TOS. That's April 1st, same time, same channel. All right. So today we're going to answer a bunch of different questions we've gotten from patients, from YouTube videos, and from our website. I want to remind everybody, please hit the like button. The algorithm helps us reach more people. And if you haven't subscribed already, please subscribe. We appreciate everyone who has. And hit the little bell if you want to be reminded every time we have something new. Now let's get to some of our questions. First question: why are overhead athletes prone to developing TOS? Now, you may have heard of a pretty famous basketball player just being diagnosed with a blood clot in his arm, and we're going to get to that later. But overhead athletes, including volleyball players, swimmers, baseball players, particularly pitchers, rock climbers, among others, are prone to developing thoracic outlet syndrome. Not only do they have to place their arm far above their head or back behind the plane of their neck, but they're usually doing it with a significant amount of force, and they're doing it repetitively. There are several different types of thoracic outlet syndrome, as you know. The most common type is the neurogenic type by far. But in these athletes, actually, it's not uncommon to see a higher than usual incidence of venous thoracic outlet syndrome, where there's a blood clot that forms in the subclavian vein. It's called Paget-Schroeder syndrome, named after two famous doctors, one in England and one in Germany, or Effort thrombosis. But it's when a blood clot forms in the large subclavian vein that returns all the blood from the arm to the chest. And it's because of the position of the arm, the frequency of using the arm in this unusual position, and the force of the muscle contraction. Our next question: my attorney told me that motor vehicle accidents often result in thoracic outlet syndrome. Is this true? Yeah, I don't know that there are a lot of numbers on this specifically for TOS, but part of that may be due to the fact that the diagnostic criteria for thoracic outlet syndrome have changed a lot, and they remain somewhat subjective, especially without imaging. As you may have heard, there are not great tests, EMGs, plus or minus, although people have used this MAC test, MABC. But the criteria are mostly clinical, that the doctor suspects it, and there's no strong single test. So the reason I say that is because whiplash injuries are very common, and they're usually divided into acute whiplash and chronic whiplash associated disorder, longer than 6 months' time, where patients have persistent pain. I consider whiplash as local pain, injury to the muscles that hold up the neck, and there are a number of them, including the anterior scalene muscles, that get stressed, strained, little micro tears, little hemorrhages, and over time they heal with more fibrotic tissue and scar, and they're less flexible, and they tend to be contracted. But if the pain radiates out into the arms, especially if it's going into both arms in a typical pattern for TOS, then it's more likely to be TOS and not just simple whiplash. Acute whiplash goes away. So I think that TOS is fairly common in motor vehicle accidents. The mechanism is likely the same as what happens with whiplash, where the head and neck take a series of abnormal motions from the initial impact to the muscle contractions trying to control that impact, and to the head restraint, then hitting the head again. The next question is the following: a study I had showed compression of the subclavian side on the affected side. Showed a compression of the subclavian side. I'm going to start this one over. A study I had showed compression of the subclavian vein on the affected side when my arms were raised. I watched one of your videos where you referred to the, quote, forgotten space, unquote. Can you describe this space, and how would you treat it if it were abnormal? So I paraphrased the question a bit. There are tests such as ultrasound that can show compression of the subclavian vein or the subclavian artery. But let's remember our anatomy. This is a picture of the thoracic outlet from the side, or a lateral view. And you can see the anterior scalene, first of all, inserts on the first rib. Behind it is the scalene triangle, which includes the subclavian artery and the brachial plexus. But in front of it is a subclavian vein. Now, that subclavian vein goes through the prescalene space. It's a different space than the artery and the plexus. And you can see that it is dependent on the position of the clavicle, that the first rib does not move that much, and that the anterior scalene muscle prevents the vein from sliding backwards. You'll see a subtle muscle underneath the collarbone or clavicle called the subclavius muscle, and there's an associated tendon with it, the costoclavicular tendon. Now, when the tendon or the subclavius muscle have too much space, they occupy too much space in the prescalene space, you end up with compression of that vein. And if you have repetitive motion, as we described in overhead athletes, or you have a single traumatic event like a motor vehicle accident, you can damage that vein and allow blood clots to form. I will point out that compression of the vein by itself is not venous thoracic outlet syndrome. There was a study done at Northwestern Hospital a couple of decades ago by CT scan, and they found that a lot of normal people with their arms up had compression of that vein. So if you have an ultrasound or a CAT scan or an MRI, and the arms are overhead, and you have compression of that vein by itself, that is not venous thoracic outlet syndrome. It depends on the symptoms that go with it. Thank you. The next question is it possible that after TOS decompression surgery, the brachial plexus gets shorter? Is it possible that scar tissue could cause this? So the brachial plexus length, I don't know of any documentation in the medical literature where the length of the brachial plexus or its components has been measured. And in general, it's accepted that the brachial plexus, like a lot of peripheral nerves, will glide through the tissues. And no matter which path it takes, it has to glide through some of those tissues to accommodate different positions of the arms, the shoulders, the hands, or the neck. What we believe happens is that after surgery, after the nerves are manipulated to allow for dissection of the anterior or middle scalene muscle, that they respond by oozing blood products such as fibrin, and that scar can form, or fibrotic tissue, or what surgeons will call granulation tissue, around the outside of the plexus. In addition, many surgeons will describe an aggressive neurolysis where they find scar tissue around the brachial plexus when they get into surgery, and they remove it. They actually peel it off of the brachial plexus. And that, again, may break little tiny blood vessels on the surface of the plexus and irritate the plexus and cause the formation of new scar tissue or granulation tissue. So we don't know that the plexus shortens, but certainly I have several post-op cases where the brachial plexus gets inflamed and irritated after surgery, and that can contribute to ongoing problems even if the space is decompressed and there's no further compression of the brachial plexus. Next question: why does the TOS patient perspective, in quotes, always seem to include multiple surgeries? So this is a complex question, and it's an interesting question. The success rate for TOS surgery has classically been described as 85% of patients feel better, feel good to great shortly after surgery. And at 2 years, it's about 70% of patients that still feel good to great. So about 30% of patients fail surgery. And many of those patients will go through a redo surgery. A lot of surgeons don't like that because the first surgery has often left a significant amount of scar tissue, which makes it hard to do the second operation. Now, there's questions about why that would occur. I think there's a different range of extent to which surgeons will perform dissection and removing elements around the brachial plexus. Obviously, I have my bias towards using imaging and approaching this that only certain patients get certain types of procedures, depending on what we find on imaging. This is based on the fact that we know there's a lot of anatomic variation between patients. And we know that the disease itself is caused by many different causes. So I advocate for using the imaging in conjunction with clinical knowledge to decide on limited surgery just as much as is necessary. But there are surgeons who don't need or desire the imaging, and they do the same thing on every patient pretty much until they get in there. They kind of expect to remove everything that could be contributing. And that's what leads to this formation of a lot of scar tissue in some cases. So, what we know is that 30% of patients fail surgery at 2 years, and surgeons are called on to perform redo surgery. And those redo surgeries are harder than the first ones. So 30% of patients may need more surgery, and the redo patients don't do as well as the original surgical patients. That may be why we have many patients who have had multiple surgeries, and I think that's pretty tough for them to go through. The final question is that multiple patients and interested parties have reached out to us. I'll start over again. Multiple patients have reached out to us regarding our opinion on what's happening with Victor Wembanyama. He's a famous basketball player, first overall pick in the draft, and he's having a great year, and he's an incredibly talented guy. Most of the articles I read online just stated that he had developed a blood clot in his shoulder. And many of those articles went on to describe other NBA players who had developed blood clots. And that's about it. It's not very medical. There is a single reporter who's done a great job, and I'm about to post a blog post in detail on this reporter who he's a sports journalist, and he's really dug into it, and I agree with what he's doing. The fact is that a lot of players, the NBA players who are famous and who have been diagnosed with quote unquote blood clots, have been diagnosed with actual pulmonary emboli, where the blood clots are found in the lungs. Now, in that setting, you don't know where the blood clots came from, but they came from somewhere else. And the medical literature shows us that the vast majority of those come from the legs. And what we strongly suspect is that these very tall players are cramped in airline seats, and they have to stay on those flights, and they have less mobility, and the blood doesn't flow so well, partly because of their positioning and partly because they're so tall they don't have a lot of space. And in many of these famous NBA players, clots were discovered in their legs, either at the time of the initial diagnosis or later. But the players who develop blood clots in the shoulder is a completely different story and a different mechanism. And in those patients, we should be more likely to consider venous thoracic outlet syndrome, not an airplane flight causing it. And in Victor Wembanyama's case, my blog post will explain why, but I'll state this quickly. A recent review in 2022 of a very large international registry of patients with acute blood clots. There's an earlier one performed in 2017 as well. They studied about 40,000 patients with blood clots, and only about 5% of those were in the upper extremity. And then if you take all of those with the blood clots in the upper extremity, there were about 4,200 patients, and only 200 of those, or 5%, had venous thoracic outlet syndrome. 70% plus had diagnoses like active cancer, recent surgery, immobilization for 4 days, estrogen treatment, pregnancy. These are things that do not apply to young athletes. And as one of our early questions referred to, overhead athletes, young people, get this particular disease, Paget-Schroeder syndrome, or effort thrombosis, where they're more prone to getting these injuries to their veins and blood clot formation. But what this study also showed is of the 200 patients, or the 5% who had venous TOS, that those patients tended to be younger, 20 years younger, and they tended to be male. And they tended never to have had a blood clot before, that this was the first presentation. And those are some indications that Victor Wembanyama may have thoracic outlet syndrome, in addition to the fact that it occurred in his shooting shoulder. All right. When he's using the shoulder all the time to perform his athletic feats, he's going to do what we talked about originally, use a good amount of force and a significant amount of repetition, and the arm in an unusual position overhead or in front of him. So I suspect that he's got venous thoracic outlet syndrome. Maybe we'll find that out over time. Sometimes all the medical information isn't released on these patients. But if we do hear that he's had a rib resection, I will not be at all surprised. Keep an eye on our website. I'll be hosting that blog post in a day or two. It'll have a very detailed description of what's going on. As far as we know, I'm not involved in this gentleman's care. Thank you very much for sending in the questions that we have. I want to remind people that on April 1st, April Fool's Day, we're going to have a roundtable of great physical therapists discussing how they approach TOS. And we hope you all can attend that and bring your friends along as well if they have interest in TOS. We think it's going to be a very, very entertaining talk. And the people who are presenting it have a tremendous amount of experience and knowledge. I'll remind you again, please hit the like button, subscribe if you haven't subscribed so far. And thank you. This is Dr. Scott Worden, the TOS guy. Everybody have a great week.